Well, I have to say I'm moved to see Jonathan after all these years. I'm also moved by the fact that you're really kindling a sense of digital health in the context of an Aboriginal tradition that I think is part of what I'm going to try and highlight. There are really only two ideas that I'm going to talk about today. One of them is that the inputs and outputs for our health systems are fatally flawed. That in many instances, in fact, in most instances, what we've done is digitize the 18th century quite faithfully. And the second idea is that if that is the case, then we have the opportunity probably once in a couple of millennia, maybe even longer, to completely reconstruct what we're doing and to do it, as Jonathan said, in a very patient-centric fashion. And so what I'm going to try and do is in the next 20 minutes show you some of the things that came out of my work as a fundamental scientist, working on really the mechanisms of disease. But I think as I took over the leadership of a department that has about 600 investigators in it, I realized that we were in deep need, if we were really going to be patient-centric, of rethinking almost everything that we do. This is really the goal that we all have, is this learning health system, a framework in which the highly qualified providers turned into data entry clerks for the 21st century, feed information into a matrix, and then a miracle happens through analytics, which, to be 100% honest, have been around for probably 25, 30 years in the current form, and have failed to deliver on the vision that is transformation of healthcare through an output that immediately identifies what the patient needs and then delivers exactly what they need at exactly the right time with exactly the right nuance and follow-up. So what is it that's actually missing from this picture? Well, I think, and this was actually a word map that we did after a fairly broad survey of the literature and also canvassing the 1,600 investigators that are in the Harvard system thinking about this question. And I think the thing and this was my personal focus, was information content. I think most of what we collect is so redundant and so constrained in its scale that we actually end up collecting a lot of data, but in ways that really don't add a huge amount of information. There's a whole host of reasons for that, not least the fact that we collect almost no metadata. We collect almost no exposure data. We do not think about anything really until the patients come to us and ask us for solutions to acute problems. And then I think in the top right-hand corner, one of the things that really I've learned over the last 2 years of trying to redesign, 3 years now, redesign an entire cardiovascular translational and clinical enterprise is that the biology is the only constant, that there is nothing else that actually you can trust will still be present 6 or 9 months down the line. You'll notice, and I mentioned this for a couple of reasons, that sustainability on day one is not actually in very large letters. And that's because I believe that if we do this properly, it actually saves so much money that it's instantaneously sustainable. And I'll show you some of the work that we've done to try and highlight where I believe some of the sweet spots for that are. I'm conscious of the fact that there are very few places on the planet that have the critical mass of patients, data scientists, investigators in biology, pharmaceutical and biotech companies that exist in the Sydney area. And Jonathan and I were talking about how I think ultimately what we're going to see is an effect of all of what I've just said is that there will be a globalization of healthcare in a way that has really hit almost every other industry many, many decades ago to some extent, and very rapidly hit some industries to the essential exclusion of almost all of the professionals in those industries. And what is really the subtext of what I'm going to try and tell you today is how to avoid going the way of the travel agent, who basically disappeared in essentially a 12-month period because they did not recognize how far off the mark they were in terms of the services they were delivering to their clients or customers. This is really where I've spent most of my life, is on the far, I suppose it's the left-hand side to you. up here in this top corner. I spent a lot of time working on rare alleles that cause Mendelian disease. I then spent a lot of time working on common variants that affect traits that we all have. But in reality, there's this large section in the middle which we as a community have failed to penetrate. People have even started talking about things like dark matter in the genome. When in actual fact, this is predictable from the work that Mendel did. These are the traits that we don't have assays for, or that we don't measure the conditioning variables for. So classic example of paucity of information content writ large in genetics, so that in fact many of the conditions that you see as autosomal dominant Mendelian traits turn out to be the extremes, the very extremes even of those traits. And so it's only by having much more sophisticated analysis of what's going on in their environment, what exposures they have, what happens through their lives, that you're able actually to understand why one person in the family will die suddenly and others will live to be 80, yet they have inherited exactly the same primary causal gene. Clinical trials, I think I don't need to tell anybody, have really failed. When Jonathan and I were, and I hesitate to say how much better he has aged than I, but when we were in medical school, everybody was talking about molecular medicine as if stratified care was just around the corner. That was almost 30 years ago. And this vision of having the ability to detect who's going to respond well, who's not going to respond, who's going to respond adversely, has been around in various guises for that entire length of time. What is it that's really going to drive it this time? Well, I think the sad thing is it will not be the medical profession. It turns out it will be, the reason we're going to be able to do it this time is because external forces will actually force us to do it, or will do it themselves. And then perhaps the best evidence that digitizing the 18th century doesn't work very well. Now 6 randomized controlled trials of massively dense digital collection from the home, unable to show any effect on some simple short-term endpoints like heart failure readmission or other similar care redesign efforts. All failed simply because the stuff we measure in hospital is not that relevant either in the home where the conditioning variables are distinct, or to be honest is not that relevant even in the hospital, but we create this vision that it potentially has some value. And so phenotype, I believe, is limiting in almost every area of biomedical science. What we measure is largely a function of what Osler measured, or what Osler thought it was worth measuring, the canon that was established, the physical exam that was established. We've gone on to digitize tomographically, measure a few of those traits. Perhaps some other biomarkers have become available, but in the main, what we've done is literally take that and try and digitize it. And the same applies to the workflow. I was actually stunned when talking to a very large IT company to hear that they had invested a huge amount of money in building an application that essentially managed a chronic condition based around the provider or around the clinic and not based around the patient. And the core elements that I think highlight how really almost bereft of fundamental insight we have been as a profession, and I share that with all of you, is that we measure things that are static or limited in dynamic range. They're almost all aggregates as a result of the last 2-3 decades worth of clinical trial emphasis. They're almost all free from any organizing metadata, and that actually is the thing that will completely paralyze any attempt to use AI in this space. The fact that we don't even know why or what was happening when your heart rate was 30 means that it's highly unlikely we'll ever be able to infer it, no matter how many people's heart rates we collect. This really is an example that I actually realized when I co-chair an effort in Harvard called the Undiagnosed Diseases program. I'm one of the clinical leads for this. And when we added up every single phenotype that you can measure and bill for in clinical medicine, that was the real driver, as you might imagine. The NIH was scared of how much they might have to pay for each patient that was going to be evaluated in this Undiagnosed Diseases program. It comes to about 9,800 phenotypes. And you can look in almost any other setting, the model organism phenotype ontologies, the clinical phenotype ontologies, they're all roughly identical. So it's hardly surprising that we've been unable really to understand a genome. Everybody in the room probably differs at about 10 to the 6 locations, when we only measure in toto 10 to the 4 things in clinical medicine. Far less all of the complexity that's introduced at each of the levels outlined here, transcription, proteomics, cellular connection, and then the vast time ranges from microseconds through to literally almost a century that drive much of human biology. I should have pointed out, obviously, that in the bottom corner, there is no scale on exposures. We measure really alcohol and tobacco, and by measure, I mean we take a second-hand report. Ultimately, almost everything that we do is based on this framework, which is the clinical trajectory. So in traditional healthcare, we essentially wait for people to show up with a problem. In many instances, it's actually the initial presentation of their decades-long trait. In many clinical specialties, we've begun to think about prevention, but the patients themselves, the individuals that we look after, are really very much more focused in their eyes and minds, not on whether they have long QT syndrome number 19, but whether they will live longer or feel better. And since almost everything we do is incapable of making people feel better, we really then have to ask ourselves how we're actually going to make people live longer. And I think that requires us to move the entire spectrum of what we think about much, much earlier in the course of disease. I talked about the 18th century. I really believe it. I don't even know that I'm interested in semi-subjective data that I reported a week ago if you need natural language processing to extract it. And that's not because I don't think that NLP is important and powerful. It's just that if we don't think about how we structure the data more rigorously, we're never going to get out of that vicious cycle. It's stunning that we still define diabetes in terms of sugar in the urine, literally a medieval phenotype, when we've known for almost 20 years that there are abnormalities of branched-chain amino acids that actually antedate any sugar in the urine by about a decade. But we still, because of all the implementation focused around not actual outcomes, but around managing sugar, which we've shown conclusively has no effect on outcomes, or very little effect on outcomes except at the extremes. In fact, if you were really thinking about what you should be managing in diabetes, it's acid-base balance, not sugar. But because of the fact that we focused on sugar, we've missed that entire field. And so as a result, all of these secondary phenotypes that are well described, whether it's microvascular phenotypes in the eye or in the subangular capillary beds, thermography, even the distribution of different adipose tissue locations is actually highly predictive of your risk of diabetes when you're a teenager. Even your electrocardiogram can tell you about the extent of insulin resistance, but we've failed to wrap this all into a single program. Many of the things that we laud as existing risk factors are actually the disease itself. The ARIC study, for example, did CT angiography on everybody within a week of being diagnosed with diabetes, and 100% of those individuals had evidence of coronary disease. So whatever is causing coronary disease, it's not diabetes. They're probably some downstream consequence of a shared upstream influence. Similarly with glucose itself, lipids, and many of our diagnostic tests are so focused on the late stages of disease that we end up, perish the thought, using things that were originally identified as markers of myocardial necrosis now as population stratifiers simply by building more and more sensitive tests, rather than actually trying to understand what are the statistical constraints that would allow us to build predictive models that would be truly useful. And importantly, the reason for that is the data streams we have access to are really still very, very much fixed firmly in those original limited 9,800 endpoints. So what we've begun to think about as a strategy, and I think it's one that you see emerging in lots of different areas, I don't think anything that I'm saying here is in any way unique, is to move to do in an unbiased way what has been done with genomics. If there's anything we've learned from genomics, it's that knowing where the start and the end of a data set are is quite important. And it's knowing that you can assay that whole data set in an unbiased fashion. We need to begin to think about doing that for phenotype. And in fact, that's what we were funded to do by the American Heart Association, by Google, and by AstraZeneca. And now we actually have a couple of other large partners who are coming in to work with us from non-traditional industries, which will be announced hopefully before the end of the year, thinking about how we can begin to shift the needle, not from this latter 10 or 12 slices in this arterial diagram, but actually looking at the first two. Why is it that we've been unable to identify, despite the fact we know it's present, biological metrics that allow you to, at the age of 5 or 10, when your behavior can still be modified, identify your vascular risk, identify your metabolic risk, and therefore stratify you not just for your clinical trial when you're 45 or 50, but actually for the whole of your life in a way that you can actually begin to change what you're doing. So the goal is to take generic pre-disease to essentially deep phenotype it in lots of ways, and we're taking a very broad strategy. I'll show you a couple of these, and then think about new ways of making scalable technologies to measure that, and then beginning to introduce that in existing populations at the same time as we're trying to do it in children or teenagers and change behavior. So the goal is to identify new translatable markers. Use that because it's much, much more specific to the underlying biology than is any of the arterial obstruction that occurs 30 years later, to identify the causes of those forms of disease, and then begin to build technologies to treat and prevent those disorders. We'd already done some of this in heart failure. This is work I did 3 or 4 years ago, where we began to ask ourselves, what is it that we can do in the clinic that begins to make that environment a much more rigorous phenotype collection strategy or phenotype collection venue, with a strategy to try and build the dimensionality of the data we collect. So we began to look at simple things that are readily available that you can automate in a clinic, like auditory evoked responses. You can, in 2.5 minutes, you can measure that while people are waiting in the waiting room. It didn't escape us that this actually also prevented people from realizing that they were sitting around for an hour and a half to see us for 11.5 minutes. Stride length, for example, completely bifurcates the causes of heart failure into ischemic and non-ischemic for reasons that we don't fully understand. I should have said auditory evoked responses identifies senile amyloid almost uniquely as cause of left ventricular hypertrophy. And then perhaps one of the most interesting examples we found, we spent a lot of work doing drug development to identify and developmental biology to identify the mechanisms and treatments for a condition called arrhythmogenic right ventricular cardiomyopathy. Guess what? You can actually do almost all the cell biology on a cheek swab, including the response to drug. And so there are many, many preclinical phenotypes in coronary disease that I'm just illustrating here to show you the examples. We wait for macrophages laden with lipid to become visible to the naked eye. That's literally how bad it is. We've known for 25 years that there are vasomotor abnormalities in teenagers with coronary disease, but we've never really built a technology to measure that. And what I'm saying is not that we displace the traditional interactions, the caring and healing that comes from all providers, although I show you in a few minutes that may not be as magical a property of 20 years of training or 10 years of training as we would like, but to actually complement it. So the data are actually flowing into the system rather than having to be semi-subjectively entered by us, that the information is tailored to the pretest probabilities of the folks that we're actually looking after, and that ideally we're building granular trajectories that start very early in life. And we're doing this, I'm not going to go through any of the details because I don't have time, but we're doing this at scale to try and build next generation phenotypes that actually are accessible for every trait that might be relevant to human biology, trying to find those that are truly discriminant in many situations. I will tell you that even probably the single most important thing I think we need as a community to start to tackle is symptom ontologies, trying to understand over a lifetime what people are actually telling us about themselves. But the other things that I think we can do are begin to add measured perturbations. So the metadata that we crave, the metadata that AI undoubtedly will benefit from, is actually something we can add. The saddest thing is there are only 2 things, I think, that really operate from the scale of a single molecule all the way up to a population. One of them is a small molecule. That's a perturbation that you can apply in cell culture or in a clinical trial. And yet we throw away almost all the information on drugs and their interactions with our patients. When was the last time you actually objectively measured the response to a drug intervention? Almost never. And then the second thing I think that is possibly an important perturbation is biophysical forces. And we spent a lot of time thinking, where could we actually do this? And it turns out that for about 5 or 7 years, most car companies have probably built into their systems more sophisticated biophysical sensors than exist in almost any other setting. So we actually have a large collaboration with a car company to try and dwell into how you can use that, plus other sensors, to understand what's happening to the biology of the individuals. What we need to do is to build these agnostic reclassification domains. They don't have to be based on cell biology or organelle biology. They can be based on federated data from your credit card. They can be based on your refrigerator opening times. They can be based on so many things. But what they can't be based on is the same 200 things that we decided, or somebody decided a couple of hundred years ago, were going to be worth measuring forever and ever, and doing it in a way that actually turns out not to be very systematic. It's sad, I think, although I laud the investigators for doing it, that it was last year that we showed that height is inversely related to coronary disease risk. So assays for height, as far as I'm aware, have been present for some time. The core element, I think, is to begin to redefine disease using computable phenotypes. If we're going to start from scratch, we may as well design it for the systems that we want to actually build. And so almost everything we're doing is based around the filter of trying to understand how it could be used in a completely agnostic, high velocity, high volume data collection environment so that it can actually drive directly into the system. We need to build some devices to collect these types of data, but many of them may be collected already by things that are in our environment. So for example, if we just applied the right tools to understanding what happens to people when we do administer drugs and measured their responses in a rigorous way, we might end up with much more detailed trajectory data that themselves begin to stratify the individual. It's not lost, I suppose, on many that this is also a very useful set of tools for measuring the responses of the system, optimizing cost and risk, virtual versus physical visits, as well as creating care networks. So now let me turn to the output. How can we transform what we do in clinical care? Having thought a little bit about what the limitations are and what the broad needs are of the field of input, let's think about output. And don't hesitate for a second to think that I don't realize how poorly I've performed in the last 30 years in terms of deriving better metrics for input. But I can tell you, if I thought I was doing badly in input, I've done incredibly badly in output. So this is a paper from 2013. The most recent data we have from large insurers on the East Coast of the US suggests this is not much worse than it is now. So you can see here the percentage of people for whom their A1C, this is diabetics, type 2 diabetics, A1C is less than 7%, their blood pressure and LDL are well controlled. Turns out to be vanishingly less than 20%. So that itself, I think, is something that would really challenge anybody who knows exactly what the data are for these types of interventions. And I think what I believe needs to happen is we need to devolve the stuff that we actually know to the people who are actually vested in doing it, i.e. to the patients themselves. And I think what we see here is this sort of traditional gradient of care from a novel therapy through specialty care into primary care and then to system care, except for the fact that almost nothing ever makes it to system care. We hold on to, probably less so here than in the United States, where there are financial reasons to hold on to it. But we hold on to things that are simply not professional any longer. If you have a guideline for it, it can no longer be determined to be professional behavior. And yet, that is about 40% of all the healthcare delivered in large academic medical centers in the US. I don't know what the data are in Australia, but I suspect they're probably not dramatically different. The biases in where the care gets delivered within that AMC may change. So what we've begun to think about are, in all of these areas where there is the possibility to devolve care, how can we best begin to do it? And so the traditional framework is this gradient where you have the specialist physician or the internist managing the individual. But ultimately, you can see that with the right information content, this diagonal can actually end up being a horizontal at the bottom of the curve. That a patient could manage other patients in the community, that we can actually begin to build, much the same as has happened in almost every other industry, the framework for allowing people to actually do it themselves. And I think that that challenge is something that we've sort of spent a little bit of time trying to think through how we could actually execute on it. It's worth pointing out some classic examples. So for example, a home Wi-Fi network used to require having somebody come and set it up, a professional come and have it set it up. Now, over 95% of people in cable networks in the US are able to set up their own Wi-Fi without any external input whatsoever, no matter what their education level is. So you can imagine that taking a statin or taking blood pressure medications, to be honest, is not an order of magnitude more complex than setting up a Wi-Fi network with a tunneled VPN. The traditional care relationship, I think, is at the core of what the problem is. It's obviously an important piece of how we set up the way that we deliver care. It originated in many instances probably in the earliest times of civilization. As I mentioned, about 40% of visits we think in our system are simply unnecessary. What do providers really add? And this applies to providers across the board. Well, they add cost. They add tremendous variation in care. They add arcane workflow practices. They add timing constraints. Everything has to be synchronous. They add scaling constraints. But they do bring pattern recognition. They allow you to see outliers. They do bring biologic insight, pharmacologic insight in many instances, and hopefully the human connection. But I would actually argue that probably the only unique attribute of a provider, of a professional in the healthcare system is an investigative function. That's what being a professional really means. If you go back to the Middle Ages, it was actually the ability to deal with ambiguity. So where there is no ambiguity, you don't need a professional. And what we've done is hold on to the remuneration or the systems that allow us to deliver very straightforward, guideline-driven, information-driven care in very variable ways, and not thought about how we can actually begin to move it to the individuals themselves. There are lots of reasons for this. So we looked at digital adoption in actual patients. If you look at the data, it looks like about 75–80% of people are really, particularly in the East Coast and the West Coast of the US, are high-end early adopters of digital technologies. But if you look in the bottom left-hand corner in this diagram, only about 24% of those in the age groups that actually have conditions that require therapy are truly willing or able to use digital technologies for their care. And so what we thought we should try and do is change the workflow now with a view to actually building the systems that would be relevant in 5, 10, 15 years when digital adoption rates in the right framework were much higher. So we built a system that uses advanced analytics to improve the identification of those at risk. Although ultimately the most important identifier of those at risk is the people in the system itself. That I think just tells you how the fact that we need AI to identify the patients in our systems that need our care is itself, I think, a restatement of where we might have gone wrong. Expert treatment algorithms are implemented using very straightforward software strategies that even a college or a high school graduate can implement. And that's essentially what we do. We take college graduates, now we're actually taking high school graduates, have those supervised by a pharmacist with pop-off to an RN or an MD, and we manage the entire chronic care. And we've done this now in multiple different conditions in the last 3 years, as well as building an education platform that goes directly to the patients, to their families, to their providers in many instances, and thinking about how we build the data return cycle so we can actually turn this into a real-world research platform. Interestingly, the things that are most obvious are most obvious. It's you get uniform implementation de facto. Stuff actually happens the way it's supposed to happen in the guidelines. You don't get this artisanal care where people feel like, you know what, I know this person well enough, I'm sure they only need 10 of atorvastatin. They're definitely going to get into trouble if we give them any more than that. You get agile workflow and software co-design, so we don't design the workflow around the provider or the clinic. We design it around the patient and what the patient actually needs. So we've moved almost all of our interactions to the early evening or to the weekends, which guess what, is when the patients are actually available. We're able now to train the software behind the firewall before anybody adopts it. So we actually now have almost 3 years worth in our earliest programs of dedicated data from which I can tell you very precisely some A/B testing we've done in the network that allows us to tell you what the exact definition is of statin intolerance, what the exact definition is of the need for a PCSK9 inhibitor, what the exact definition is of different subforms of type 2 diabetes based on their responses to therapy. And obviously the data return streams define those capabilities. Interestingly, and I'll show you some of the data, the navigators, these college-trained kids, actually the thing the patients like the most is that they actually think the human connection is accentuated. So the sad thing is that the elements that we have convinced ourselves are the reason that you still need to spend an hour parking, sitting in the waiting room, and then come and see me for 11 and a half minutes, is the very thing that is actually most influenced by actually having access to somebody who cares, sounds like they care, is not harried, is not rushing on to the next appointment. And we've done this now in multiple different areas, in lipids and inflammation, hypertension, heart failure, diabetes, anticoagulation. We've done obesity. We're just about to start pre-diabetes and moderate obesity. And what we've really thought through is how can we take each of these individual slices and begin to build them into an overall disease management platform. Some of the initial results are actually quite embarrassing for us as providers. These are all from our own internal sources. So these were clinics that we were in charge of. So a 40% LDL reduction and a 60% cost reduction in the first 1,000 patients that we looked after in our lipid program. You can see here the satisfaction was enormous. You can also see that the response rates in the bottom right-hand panel, there's only 22 out of 400 physicians had the time or inclination to respond. Blood pressure actually had very similar results. We had a significant reduction in systolic and diastolic blood pressure, larger than in most clinical trials. In fact, significantly larger than in most clinical trials. The averages were such that we were able to take our Medicare penalties from somewhere around 2.7 down to about several million, down to $700,000. What we've also learned in doing this, and I'm almost done, is that by redefining disease and redefining the platforms that we look at, we begin to see that there are other partners that are willing and able to help us build this ecosystem. In fact, I would actually hazard a guess that if we don't begin to join them, they will literally steamroller us out of the way because we are now perceived as part of the problem. So we worked with payers who, as you might imagine, are interested in lots of different elements of this. Probably the most important thing about all of this is it reduces all of the to and fro between a payer and the provider. You're operating on the basis of objective information. So the second that something becomes objectively indicated, it gets implemented. So if you think about it, it takes somewhere, 12 to 15 years in the US for something after it reaches the guidelines to reach equilibrium in the population, when 900 million people can upgrade their software on their phone in the first 48 hours. Why is it that it takes 12 to 15 years to upgrade your healthcare when you can upgrade your phone in such a short space of time? Pharmacy benefit managers, very similarly aligned. Pharma and biotech actually turn out to be the most surprising partners. They would far rather get a drug into the clinic in the first year after it's indicated than spend hundreds of millions of dollars detailing or driving advertising, recognizing obviously that that's not a universal phenomenon in the world, but nevertheless spending a long time getting to goal. They feel that, in fact, most of what they're doing is wasted simply because of the fact that they spend at least 2/3 of the patent life of a drug trying to persuade people to use it. Tech companies are really interested for a variety of reasons. This is the last part of the economy that they have not penetrated. But actually, they're also interested in doing this in a very different way than we would imagine. They don't want to take it over. They want to be the glue that holds it together. One of the most interesting things that I've done in the last couple of years is talk to very non-traditional companies like retail companies and car companies. We spoke to a retail company that had done a point-of-care pop-up clinic that last year recruited 400,000 people an hour for 24 hours globally. Some of these places have 900 million people touch their stores in a month. 900 million individuals touch their stores in a month. They're actually interested in just bringing affordable care, subscription type care. So one of the companies we spoke to is driving to get all of preventative health care for a subscription of less than $150 a year. If you did that, it would completely disrupt the insurance markets. To be honest, it would completely disrupt many markets worldwide. And then finally, one of the things that I think we've been excited by is that the federal government is interested in actually coming in to try and understand how to attribute value to individual interventions in individual patients. Because we never measure responses, we don't really know anything about how people actually end up responding to their interventions. So ultimately, I think with the right data return cycle, we can make this a truly learning platform. We can build care delivery and innovation into exactly the same system that we have objective clinical trial networks. Our goal as a division, I have the fortune to have 4 of the largest clinical research groups in the world in the division. I think we do somewhere around 40% of all cardiovascular trials. But that is a business where the trials are disappearing. They cost $800 million to do a pivotal phase 3 study in cardiology nowadays. We think we can get the cost down under $75 million to do the same level of fully powered study. I actually believe the other thing that we're not doing really well is moving biology, as I said at the start, into the clinic and out of the clinic. If we start to make these things part of what we all do in looking after patients, that translation loop will be accelerated in a dramatic way. So in summary, I think information content is the rate-limiting step in almost all of digital health. We need new things to measure, whether you call them phenotypes or metrics, whatever they are, and whatever they might be. It might be clicks in the record. It could be anything. But what it cannot be is digitization of legacy traits. We need to overcome the lack of comprehensiveness. That actually, I think, is probably the biggest barrier to understanding how we can use rigorous analytics and machine learning in healthcare. We need systematic approaches to acquiring the right information content, and that means building new partnerships, new ecosystems, understanding with data scientists what it is that actually makes a good thing to measure, rather than throwing stuff at them that we just believe intuitively is going to be the right stuff. And we need to actively balance broad versus deep phenotyping. You hear those terms thrown around quite liberally, but I don't honestly believe that we really understand the differences. Focus on assays for health will drive, you notice there's nothing following that. I think it drives everything. If we move things back to the point where we actually have things we measure in linear dynamic range, we define health as the absence of disease. We need to actually define it in a more positive fashion. And then I think this opportunity to reinvent everything is truly special. And I think it's happening in a way that it will, no single health system, no single individual, no single anything will be able to do it. We're going to have to do it together as a collaborative with our patients. And ultimately, I think the only thing I would add is that the concepts that we need to be thinking about, particularly given how we want to build this, are actually more from signal processing than they are from healthcare. It's signal noise, it's stimulus response pairs, it's scalability, and ultimately, it's real systems. I would like to thank these individuals. As I said, there are about 1,600 people in the Partners Network that work on this. The key groups that I think have been most helpful are our overarching health record. So Greg Meyer and Ann Klebanski run our EHR and the research components related to it. Our research computing, including the software teams that we work with directly. My group, who has a lot of both innovative clinical trial work, innovative phenotyping, and then obviously the Partners Connected Health team that for about 25 years has really pioneered how you integrate devices and other data streams into the clinic. And then most recently, our clinical data science group funded by GE and NVIDIA has really transformed how rapidly we can build machine learning algorithms to take these new data sets and start to implement them in the clinic. And I'd like to thank Jonathan for the invitation to come and for the stimulus to give this talk, and I'd like to thank you all for listening.